Welcome, everyone, to the Cleft Palate Craniofacial Journals podcast and video interview. I'm Pat Chibbaro, pediatric nurse practitioner here in New York, and really happy to be your host. And of course, I'm really happy whenever I have a good friend of mine that I can do a podcast with. And that is Dr. John Girotto, who is part of the group at Helen DeVos Children's Hospital in Grand Rapids, Michigan, not in Ann Arbor, where our kids went to school. Go Blue this year. Yay, you did it. Anyway, the name of the paper, which hasn't come out yet on Online First, but I think you'll see it soon, is Timing of Alveolar Bone Graft and Barriers to Care. I want to read the author's, John Girotto, the corresponding author is with me, but maybe you'll help me if I get any of the names wrong. Elizabeth Bushong, Darren Patman, Hannah Hershey. I knew I was going to get that one wrong. Yeah. Is it Kyler Huffman?
Yes. Yep.
Anna Carlson and John Girotto. And so who's who from where? I see some are physicians, and it looks like it's your team or part of your team. So, and I mean, that's what we're all about in the ACPA, right? It's all about the team. So who are those other authors before we talk about the paper? And first of all, thanks for joining me.
Oh, Pat, it's always good to see you, and we'll be at the ACPA in a week, so it'll be great.
Yay.
My daughter's a Michigan alumni as of last spring, but we run the Michigan State residency programs, so it's
oh no,
I don't get a green paycheck, but that's okay. So Dr. Carlson and I are our craniofacial surgeons who do the cleft care at the Children's Hospital. She's a Duke alum and then a CHOP fellowship grad. And then the other folks are kids that want to be plastic surgeons, right? So two of them are our medical students, and Elizabeth just matched with us to do her residency with us literally a couple of weeks ago. And then Hannah is our research fellow. So she took a year off for our funded fellowship, and she's got
Fantastic.
7 papers on at the Midwestern. She'll be in Denver with us as well. I think she got 3 or 4 things on at the ACPA. And we even have some undergraduate folks. So as you were saying, part of the nice part about team is building people up. I mean, the last thing I need is another publication on my CV, but it's inspiring some of these guys to ask questions and then shepherding them through the process so that they can advance and be excited about cleft care is great.
Oh, 100%. I remember, before I retired, and now it's going to be 2 years almost since I retired, believe it or not, even though I don't think I'll ever retire from this craniofacial world that I love. But one of the things I really loved was working with the medical students when they would come to me to really, understand these patients, not just about the data, but who are these patients and families. So I always enjoyed that. And I was always really happy for the students when those papers came out and their names were on them. And I know how hard they worked. So that was great. Go ahead.
Oh, I was going to say, they ask new questions and they remind you how exciting this job is.
You're absolutely right.
So you might be doing it every day and just like, it's another day in the office, and they come in with eyes wide open and really excited to see what you do.
Exactly. Now, this paper is based off of a talk the work that you did that you presented last year. So I always want to know what an alveolar bone graft. My God, there's so many there's controversy about it, when to do it, what and what are the barriers, and so it's something that I know was a big struggle for us, was getting these kids to the OR at the right time, and what were the challenges. So I wonder if what was the motivation for your group, to look at this issue.
Yeah, Pat, that's a good question. If you're as you said, get into the operating room at the right time, whatever your team designates that to be, most commonly, late mixed dentition. And if you're delaying that process, then your complication rate goes up, right? And that gets very frustrating for everybody involved, or you lose teeth, the bone graft doesn't take, whatever it might be. It's much more difficult when the kid's 14 than when they were 8 or 9. So as we struggle with those folks, the question is, well, how come? Why are these kids showing up when they're 14? Is it my fault from a scheduling point of view, or would we lose them to follow up, or where is that error in care, and how can we better address that to make it better, right? What deficiencies are we doing as a team that we can support folks on their cleft care journey? So I mean, that's kind of the question. So what can we do better to help them out?
Absolutely. And this is one of those surgeries that you really want to optimize the timing, because you do not want to go back to a family and say, you know what, we don't have enough bone, we need to do this again. Man, I remember those conversations and having to go in those rooms. I remember there were times where sometimes the surgeons would say, you go in there and tell them, because they didn't want it, and it's a surgery that is not fun for the kids. I would say this is the surgery that they hate, because one of the reasons, besides the discomfort after, is it takes them away from their sports, from their things that they love to do, and so that's why I think, I'm really glad, that we continue to try to figure out, how we can make sure that we do this, at the right time. So maybe you can give it a bit of an overview of the paper, and obviously it was something that you presented last year, so I'm going to guess that you're building on it.
Right. So it's basically tracking our kids over 10 plus years, and we had a couple hundred bone graft patients in that group, and then looking at their their demographic data, their social data, their insurance status, where were they getting care, complications after, timing of the bone graft, either early or late, essentially, or on time or late, and kind of how that sorted out, and then just essentially doing the regression analysis to identify where things come up. Now, I'm not smart enough, but our statisticians also do that backwards. So you do the regression analysis and you say, oh, I think it's these three things. And then they turn the question around and say, well, if it's one of these three things, does it lead to delayed care? So it's an interesting statistical maneuver that I have no knowledge of. But
I know. I have to say, I saw that. I was like, what the heck is that backward thing? What is that?
Yeah. One of the really nice parts about our research team is that they just employ statisticians. That's what they do. They're not, and you just call them up and they're like, sure, what are you doing on Wednesday? And they're almost entertaining themselves as much as anything else,
Right.
But yeah, so then they did the backwards analysis, which kicked out some of the variables that looked like it was leading to decreased bone grafting. And I don't think it's a surprise to people that are watching this, but the insurance status of the family and the kid was our strongest predictor of delayed bone grafting, right? So if you're on public insurance, Medicaid, more likely you were unable to have your bone graft on time.
Right. So, it's as I was reading it and reading through your discussion and I was thinking to my team and, I know obviously we know that every team around the country has a different configuration of their team, who's on it, who's together, who's out in the community, and those challenges. And I was thinking, my team has an orthodontist that happens to be right there down the hall from us. Like, we're all together. Right. We know we have an ideal situation. But I was thinking, I'd love to go back and take a look at, and it's funny because when we go to the meeting, I'm going to ask my orthodontist what he thinks about this, and so I wonder, when you drill down on, insurance, what is it about it that makes it, the challenge for these patients and for you to get them to the OR on time?
Well, so this is the second paper that's going to be presented here in Denver in a week, right? So we, my hypothesis is exactly the same as what you articulated with. We do not have orthodontists that we employ. They're in the community, so they volunteer, et cetera. So I'm like, that's got to be it, right? These kids can't get into the orthodontist. They can't afford a set of braces. So our foundation initially set up kind of a contracting basis with about 5 of our orthodontists as a way to financially support, kids who are in need, et cetera. And that's plugging its way through the lawyers and, what's, as you can imagine. But so effort number 1, which hopefully will be paper 2 years from now, is can we assist in covering those kids orthodontically rather than employing our own person?
Right.
So that was kind of the supposition and the take home. Interestingly, though, Elizabeth presented this paper at ACP last year, and the LSU team, stood up and said, "Hey, we have a dental school and an orthodontist, and we do braces essentially for anybody. I mean, it's like free. It's like Medicaid, and we still have the same problems you guys have." So, Elizabeth and I sat down with them at last year's meeting, and we shared data and gathered data all this year. And so looking at the LSU data compared to ours, it's still the insurance predictor, even though there's access to essentially free orthodontic care.
Right. So it's interesting because I think one of the reasons we were able to have our own orthodontists on site is because we have a foundation that funds X amount per year to cover nasal alveolar molding, all of the work that the kids would need who either are uninsured or underinsured. But that's why I think it'd be so interesting, because what you said with the LSU team, they still have those issues. And so before we got on this podcast, we already were starting to talk about some of the issues. And, as a nurse practitioner on the team, I remember my social worker and I used to sit together and look at these kids and think, okay, what is the barrier? And I think it's almost, and you say, it's related to insurance, absolutely. And so I think it's what is that socioeconomic status of that family? And it's almost like you have to, every time you have a kid in your program, you really, from the get-go, have to look very carefully at what their resources are and what their challenges are going to be. And almost like really early on, work with that family to try to figure out how the heck are we going to get this on time? I mean, my social worker, God bless her, she would send a car if she had, she'd get some funding to send, Medicaid you can get, in New York at least, you can get some funding for transportation. It's a lot of work. It's a lot of work. And I know, being at the ACPA, I've spoken to a lot of teams who maybe don't have a full-time social worker, maybe they share one. And so I know how lucky I was, which is why I'd still love that at the meeting, I'm going to get my orthodontist and say, Alicia, look at this, because we have so much of the resource that, that you're trying to build into your program,
The insurance status is just a marker for being kind of under-resourced.
Yes.
So then the barriers are, I can't take time off work. I don't have money for gas. I don't have a babysitter for the other kids. We can't get routine dental care, and so now the brackets have to come off because we have cavities. I can't make it's all the other difficulties that go along with it. The Medicaid is just a little bit of a marker for that. Right?
Yeah. I mean, especially when you have, if you're able to build in funding either within your own team or in the community to get the orthodontic. So I think it just shows it's never one thing. It's never one thing. And it's interesting. I used to have these conversations with the surgeons, like, why can't we get this? Like, I don't understand. We have our own orthodontist, but when we sit down with them and say, okay, here's a situation. You have a single mother. If she takes off from work, she's going to lose money. The other kid, and so I guess the question is, for us as teams, it's, what else can we do? I feel some days where, and I think this is where we have to just say to ourselves, we're doing the best we can. Are we doing the best we can? And if we are really doing everything within our own community, what else can we do? And I do, and it really shows that, the value of doing multi-center, where you'd say, what is this just us, or, what else is going on? So you were talking about you're trying to get funding to have orthodontic care covered. anything else going on, or any other thoughts about how to make this better?
Well, that's the step we're working on, number one, right? And then the
Yep.
other is a Delta Dental grant to try to build a state database, right? So, and that's pending. But the experience at the University of Michigan with a dental center might be very different than ours without a dental center. And the experiences in Detroit are very fragmented with kind of smaller groups of people providing a team experience,
Right.
in Ian's old center or at Children's Hospital, Michigan and Detroit, I mean, so, but if you can kind of see who's good at what part of that also,
Yeah, I think it really shows what a complex issue it is when families are under resourced, where you really you have this top-notch team, you're setting up ways for them to get the very best care at the right time, and there are these barriers. And I think one of the things I just really feel has helped me with my team was, as I said, really identifying these families at risk, so to speak, and just pouring everything we can into them, knowing that we're not gonna fix it for all of them, but I think we can make it better by really, focusing in. And that again is why, and it's not something that the surgeon, can't do that. It needs to be, the whole team. And so, and I'm really glad that you have, and this is one of the things I think is really good for medical students, is to see these issues before they then spend their residency in the OR, really not dealing with these issues, because that's not what their residency is really about. I mean, it should be comprehensive, but it's so much of it is their training and getting their skills down. Then they get out and into the world. And this is why I think it's important with the fellows to see, because they're going to go out and start in practice. It's like, it's not just about saying, okay, this kid needs a bone graft at this age. I think it's just, it's what it, Dr. McCarthy used to always say to the residents, you have no idea what it takes to get this child to the table, and I think that is, and this paper really shows, how we try to do our very best, to get them to the table, in a safe way and at the right time. So I'm excited you said you're going to present more at this meeting next week. Tell me again
the joint paper with the LSU data, right? Which says, I was hoping would say having your own dental team on, it fixes everything. So I could turn back around to my crew and go, see, I told you, but
yeah. I mean, I even know, I mean, I was on a team for 34 years and always had our own orthodontist. And there are always these challenges with this particular surgery. I would say that, and also we had a dental school down the street, and so we had a lot of resources, but I think it goes to the point of, and I think doing that backward thing, really helped to show that it's not just that, that's just one piece. So I think it's really, really great that I think what you did was great, and it just shows the need for the team, and it shows a need to look at other teams and what they're. That's the joy of, I think, our organization and our journal. So I think that's great. I wanted to ask you before we wrap up, what you have medical students, you have residents that are doing work, and you are an experienced surgeon, and by the way, I posted that thing on Facebook with all of us from 8 years ago.
Oh, I know.
I think we all look the same. And we'll be at that bar again looking the same. So
can't wait.
I can't wait. I wonder what advice you would have for anybody who's listening that, is either a student or a resident or, wants to pursue something in, research wise. What advice might you have for them?
Pat, I think it's the two big things are first, you got to use your resources. Yeah, and you got to know where they are. Ask somebody where they are. And I talked about our statistics crew, right? I mean,
Right.
Darren, who's also one of our residents now, but is on this paper. You know, he can do almost all of his own stats, but it just takes a long time.
Yeah.
So you know who your resources are, so you can lean on them while you're doing something else to advance, writing the discussion, whatever. And just lean on those kind of resources. And the second one is it has been a theme for me for a long time. It's persistence, right? So I'm a baseball fan, and so Bull Durham is one of my favorite movies. And Christ Days says it to Nuke. He says, you know what the difference is between hitting 250 for a year and 300? It's one base hit a week. That's it. Over 168 games, and it doesn't have to be a home run. Just it can be a dying quail. It could be a ground ball with eyes. One more base hit a week, and you're going to Cooperstown. Right.
There you go.
And the same thing's true for trying to do research and stuff. It's like do one part of it today, and when the IRB sends it back to you and you're all really frustrated, it's just persistence. They'll get through it. You just have to kind of keep at it and don't just give it up because it gets a little difficulty, in the paperwork.
Yeah, and I think that's great advice. I think also just to take a minute and remember that what you're doing could be helpful to a patient. I always think that's a great motivator for me. It's like, okay, one thing can I do today? One additional thing that could be making me crazy, but it's going to help that family. And so. No, I think it's, I was really glad to see it pop up that, that this paper has come out. And let me read it again. It's Timing of Alveolar Bone Graft and Barriers to Care. And this is the group from Helen DeVos Children's Hospital in Grand Rapids. And this, let's see, Elizabeth Bushong, Darren Patman, Hannah Bershey, Kyler Huffman, Anna Carlson, and my good friend, Dr. John Girotto. I'm looking forward to the meeting, to hearing this follow-up and to hearing from other teams, because I know you'll get a bunch of input, from them. And so thanks for your work, for supporting all those millions of medical students and residents over the years. And, you're one of my favorite people. And so thank you so much for doing this. Really appreciate it. Even though you have that Michigan State hat on, it's okay.
Thanks for having me, Pat. I look forward to seeing you in just a week.
Absolutely. Take care. Bye now.